So we're next going to segue to the psychiatric and behavioral symptoms that can come up in HD. And I'm going to repeat this again from the beginning, that this definitely is not going to cover everything. There are a lot of different things that can come up. And again, everybody's journey is different. We're going to try to talk about some of the highlights. So just like the motor symptoms, psychiatric symptoms often begin before the formal diagnosis, and they evolve through the course of the illness. They don't look the same at every phase. Common psychiatric symptoms that occur include depression and anxiety, irritability, apathy, sleep dysfunction, and many others. These symptoms all can exist together. They can all influence each other, and not just within this list. They can also influence the motor and movement symptoms, the cognitive symptoms. Everything is related. So nothing really exists in a vacuum. So this is a great figure from a recent expert review on addressing psychiatric symptoms in HD. And I can't read it from here, and that means you probably can't read it from here, but it reiterates in general the principle that you and your loved ones are an integral part of the care team. And so you are the most important source of information. And so it's our job to talk to you about what's going on, learn what's important to you, also look at the other medications that are there, other medical problems that are there, and then together make informed decisions about what to do about these different symptoms. So depression looks different for different people, and it can look different at different parts of the illness. So we classically think of depression as feeling sad, feeling hopeless, feeling helpless. Sometimes that's how people who are depressed feel. Other times people who are depressed feel not very much. They feel empty, flatlined. And sometimes people who are depressed actually just feel more irritable. They find that they anger more easily. It can look different for different people. It is one of the most common and significant psychiatric symptoms in HD. In pre-manifest and early stage individuals, cognitive behavioral therapy and psychotherapy can be very helpful. Therapy and counseling can be helpful in every stage of HD. Talking to a mental health professional is something that can really help at just about any point. Physical activity and social engagement are helpful protective tools for depression. Unfortunately, that's been really tough over the last 2.5 years, but this community is incredibly robust, and so many things have been coming together in large part through Help for HD to try to maintain that social engagement that's so vital. There are also lots of medication options for depression. Again, that's pretty small up there, and the point is to really just illustrate what's there. So the first class that we use of class of medications is SSRI. So these include medicines like sertraline or Zoloft, paroxetine or Paxil, fluoxetine, or Prozac, as well as a number of others. Another class that we use very often, especially first line, are SNRIs, and these are duloxetine or Cymbalta and venlafaxine or Effexor. There are other medicines that aren't in those classes that we also use quite a bit, especially because they may have other beneficial effects on other symptoms that come up, which is another theme we'll tie in at the end. So those include medicines like mirtazapine, trazodone, bupropion or Wellbutrin, and others. Suicidal thoughts and suicide is a very important topic in HD. It's a hard one to talk about, but it is important. So these can occur before and throughout the course of the illness, and they should be screened for when you're being seen by your HD doctor. Talking about this is important. There are some risk factors that we know for suicidal thoughts, including uncontrolled depression, social isolation, and impulsivity. So this can be treated with lots of the same tools as we've talked about so far just for depression, but preventing these thoughts is also very important by identifying those risk factors, the uncontrolled depression, social isolation, and impulsivity, and opening non-judgmental lines of communication with your HD team. It's also important to consider the safety of the home environment with respect to things like firearms or dangerous medications. So irritability is also fairly common in HD. People who have HD can find that they have a shorter fuse. It's easier for them to become irritated or angered, and sometimes people will have responses to irritation that may be undesirable to them later on. There are some common provoking settings that can lead to a higher risk of irritability. Those can include impatience for something that is about to happen, or being hungry, frustration with functional difficulties, or fatigue. Exploring these situations and triggers with the person with HD and their loved ones is really important, because one of the most helpful ways to intervene on this is to identify some of those situations and see if there are different changes in the environment that can be made or in the daily routine. Sometimes that's enough to really help out. In addition, there are some specific diversion strategies that can be gone over with, say, a therapist or social worker on your HD team. And so these are different strategies that can be used by family and companions and the person with HD to avoid some of the more confrontational situations that can come up. Sometimes medications are necessary for irritability or aggression. Thankfully, many of the anti-chorea medications like risperidone or olanzapine are also helpful for irritability and aggression. And so, as a theme that, again, we're going to come back to, using medicines that have multiple benefits can sometimes be really helpful. In addition, there are some mood stabilizers like carbamazepine or valproic acid that are helpful, as well as SSRIs, which were one of the first-line medicines we mentioned for depression. So apathy is also quite common. Apathy is a lack of motivation, a lack of drive, a lack of goal-directed behavior. So somebody who maybe used to volunteer to do different chores or go out for a walk every day or do a weekly poker night, they may withdraw from some of those behaviors. This can occur in lots of different settings. So depression commonly occurs with apathy, and they can be interrelated in a person. Sometimes a person who doesn't really have any other depression can also have apathy just on its own. Sometimes it can arise when there's frustration with activities that are maybe more difficult than they used to be for a person. Another important feature about apathy is that it may or it may not be distressing to the person who has HD. Sometimes it is very upsetting to them. They feel that lack of motivation. They feel that they don't have the drive to do things that they used to really enjoy doing. And that is a really hard thing to experience. Other people with HD don't really have a big problem with that. So really exploring that's important, because often the apathy and the changes and reduction in behavior can be very distressing to family or companions, but it's really important to talk about this and find out what is the impact of this symptom on a person's quality of life. Some things that can be done that don't involve medications for apathy are maintaining a schedule and a routine. Engaging in scheduled activities out of the house can help. So as an example, courses of physical and occupational therapy can sometimes help both of these things. It provides an external schedule, it provides physical activity, and it also helps balance, coordination, mobility, or whatever else that therapy might be prescribed for. It is also very important to identify and treat underlying depression or sleep dysfunction, because both of these things can cause or worsen apathy. There are some medicines that can worsen apathy. So again, screening the medication list, looking for anything that might cause this and trying a lower dose or switching to a different medicine can be helpful. And that's particularly important with some of the anti-chorea medications. Sometimes we prescribe medicines to specifically try to treat the apathy. So oftentimes these are more stimulating medicines. Amantadine is one of them. We mentioned that early on as maybe a very weak anti-chorea medicine. Other stimulants like methylphenidate or Adderall and Wellbutrin. Sleep dysfunction is a huge issue in HD throughout the entire spectrum of this can show up again in lots of different ways. So some people have trouble initiating sleep. Some people have trouble maintaining sleep. Oftentimes people have difficulty with both. And this often begins before diagnosis and can peak in the early to mid stages. Later on in the course of HD, the amount of time spent asleep often increases, and sometimes quite a bit. And in addition to increase in time spent asleep, changes in sleep timing and rhythm occur. And so people might be going to bed much, much earlier in the day or much, much later in the day, and they may be sleeping until 11, 12, or even 1 p.m. So these changes in sleep rhythms can be pretty common as the illness progresses. So what can we do about sleep dysfunction? First, we try what we call sleep hygiene, which never really understood why they use hygiene there, but sleep hygiene are different non-medicine options, behavioral changes in the routine that a person can do to try to support a healthy sleep cycle. We'll talk on the next slide about some of those examples. Sometimes medication is necessary to try to help and support sleep, especially because of how central it is to quality of life and how it can affect all of these other symptoms we've been talking about. So oftentimes a first-line medicine, especially if somebody has difficulty initiating sleep, might be melatonin. This is a pretty natural medicine. It's a hormone that our brain makes. You can buy it over the counter at most grocery stores. And starting with a low dose, like 2 milligrams or 5 milligrams, 2 hours or so before bedtime can sometimes help. Sometimes we need to use more prescription medicines. And so mirtazapine or trazodone, especially, are often very helpful for this. We also mention those medicines in terms of being effective for depression. So again, there's that principle that sometimes medicines help more than one thing. Quetiapine is a medication that's in the same family as some of the anti-chorea medicines, the neuroleptics, so risperidone and olanzapine. Quetiapine doesn't have as much activity against chorea, but it can help more with sleep. We try to avoid medicines like Ambien, some of the more sedative medicines, because that can lead to some unwanted side effects, feeling really tired or foggy the next day, impairing balance, impairing speech. So we avoid those when we can, unless it's a sort of real crisis situation where there's really just no sleep occurring. One possible treatment that has been studied recently and found to be very effective in general is cognitive behavioral therapy, specifically for insomnia. This has not, to my knowledge, been tested in the HD population, but it is something that I think would be worth looking into. This is a specific course of CBT that addresses different sleep behaviors, sleep timing, and associations between sleep and other symptoms like anxiety. It's something that's maybe worth kind of thinking about or asking about. And finally, it's also important, again, to always to zoom out and keep someone's mind open. So thinking about other general medical contributors to sleep quality, like obstructive sleep apnea. Identifying something like obstructive sleep apnea is very important because that has lots of other health consequences like cardiovascular disease or stroke risk. This is a big slide with lots of words that is actually from my note template for sleep hygiene. So when I'm talking to somebody who has difficulty with sleep and I say, we're going to do sleep hygiene, and they say, I don't know what that is. And I say, here we go. This is a big list of different things that can help. Some examples are avoiding devices with bright screens before bedtime. A lot of our sleep is, our natural sleep cycles are in response to cues like bright lights in the environment. So avoiding screen time before bedtime can be helpful. Limiting napping during the day is also very important. Physical activity and exercise when done early or in the middle part of the day can be really helpful for supporting sleep, but avoiding vigorous physical activity right before sleep is helpful. There's lots of other things on here, and we'll see maybe if we're interested, we can put this together and disseminate it out. But you can also find this stuff just by Googling sleep hygiene as well. But this can be really helpful and avoids medicine side effects and stuff. So tying all of this together, we've talked about motor and movement symptoms. We've talked about some behavioral and psychiatric symptoms that come up. We've talked about how we can treat them. And I have said lots of strange medication names that come up. And this is how I want to tie this stuff together. So doing the most with the least. So lots of these medicines can treat multiple different symptoms. And sometimes a single medicine can treat both a motor and a psychiatric symptom. In addition, some medicines can help one symptom while worsening another one, and all medicines have side effects. So some examples of specific medicines that we've talked about. If you take risperidone, risperidone is oftentimes the first line medicine for chorea, and it's also really helpful for irritability. So it's an attractive medicine for a lot of situations, but it can worsen slowness and stiffness, and it can worsen apathy. I chose a red and green in terms of making something worse or better. It's a weird Christmas theme that I'm a little bit late on that, but that's what the colors mean. Similarly, tetrabenazine helps chorea. It can help something like tics, but it can worsen depression, and it can worsen slowness and stiff. When you look at mirtazapine and trazodone, they can help both sleep and depression. So those are really attractive medicines in a lot of cases. So the point of this is that the treatment of your HD symptoms is a conversation with your doctor. Your voice is important, and keeping this in mind, that it's always a good idea at every visit to zoom out, look at everything that's prescribed, and think about everything that's going on. Because again, one of the other themes is that symptoms change throughout the entire course of the illness. The motor symptoms are not the same every visit, and the psychiatric symptoms are not the same every visit. So revising this frequently is helpful. So final considerations: motor and psychiatric and cognitive symptoms can begin before a person is formally diagnosed, and they can be treated early as well. So treatment needs and goals change throughout the course of HD. A multitude of non-medication tools are available to help optimize a person's quality of life, regardless of disease stage. That's ultimately what our goal always is. There are lots of medicine options available as well. All medicines have side effects. Some medicines treat more than one thing, and treating the most symptoms with the fewest medicines is an important goal. And finally, you and your loved ones are at the center of a team of multidisciplinary providers. So I just want to thank Help for HD for putting this on and all of the incredible, amazing things that they do, especially through COVID. I'd be here till next week if I tried to list all of them. I want to thank all of our patients and our families at our clinic for trusting us and constantly educating us. And I want to thank our team at USF. This is all of us. We're a big team and we're a big family, and I'm grateful every day to work with them and to work with the HD community.